All right, today we're going to build a clinical framework for genetic kidney diseases. If you're a med student, a resident, or a fellow, this is for you. We're going to walk through how to think about these complex cases from the initial workup all the way to management. So let's jump right in.
Okay, so picture this. You're in clinic. A patient comes in with kidney function that's been slowly getting worse. And then they mention, oh yeah, my mom and my uncle both had kidney failure. This happens all the time, right? And it's that classic trigger that should make you think, could this be genetic? But the big question is, where on earth do you even start?
The most important thing to remember is that your first step is usually a visual one. A simple kidney ultrasound is going to be your best friend. It gives you this incredibly powerful fork in the road, splitting your entire differential into two main pathways. Just that one finding, cysts or no cysts, is going to guide your whole workup. It's a game changer.
So let's go down that first path. What if the ultrasound comes back and, yep, it shows cysts? We are now officially in the world of cystic kidney diseases. And these are conditions where the kidneys can get absolutely massive.
The heavyweight champion in this category, the one you absolutely have to know, is autosomal dominant polycystic kidney disease, or ADPKD. And look, this is not some rare, once-in-a-career diagnosis. It is the #1 genetic cause of kidney failure, period. And it's the 4th leading cause overall, right up there with diabetes and hypertension. You will see this.
And this image right here shows you exactly why it's so devastating. I mean, just look at this. The normal, smooth, bean-shaped kidney? It's gone. It's been completely wiped out and replaced by these countless fluid-filled cysts. This is what happens when you have mutations in the PKD1 or PKD2 genes. You can just see how this process would eventually choke out all the healthy kidney tissue and lead to failure.
So, what are the clues you should be looking for in clinic? Well, very often the first sign is high blood pressure, sometimes showing up decades before the kidney function actually starts to drop. Patients might also come in with blood in their urine, a chronic nagging back or flank pain just from the sheer size of the kidneys, or complications like recurrent UTIs and kidney stones. If you see this constellation, especially in a younger patient with that family history, ADPKD should be right at the top of your list.
And the prognosis is no joke. This represents the chance that a patient with ADPKD will need dialysis or a transplant by the time they're 70. More than half. It really drives home why getting an early diagnosis and starting management is so incredibly important.
Now here's something that's really key. ADPKD isn't just a kidney disease. Over 80% of patients also get cysts in their liver. But even more critically, about 5 to 10% have these dangerous berry aneurysms in their brain. This is exactly why we have to think about screening for them, especially if there's a family history of a stroke or a brain bleed.
Okay. A really important differential for cystic disease is tuberous sclerosis complex, or TSC. Now, while both can cause cysts in the kidney, TSC is a whole different animal. The thing to look for here are angiomyolipomas. These are benign tumors made of blood vessels, muscle, and fat. And crucially, TSC is a true multi-system disorder. You'll find tumors in the brain, on the skin, in the heart. The pattern is just completely different from ADPKD.
Okay, let's rewind. What if that initial ultrasound came back differently? What if the kidneys were a normal size, or maybe even a little small, with no cysts to be found? Well, now we pivot and go down our second major pathway, the non-cystic genetic kidney diseases. And with these, the diagnosis is all about recognizing much more subtle patterns.
Yeah, without a big, dramatic finding on an ultrasound, you have to become a bit of a clinical detective. You're piecing together all the little clues from the family history, the urinalysis, how fast or slow the disease is progressing, and any other symptoms the patient might have. It's really about seeing the whole picture.
So a classic pattern you need to know is ADTKD. The triad here is pretty straightforward. A slow, steady, relentless decline in kidney function. Small kidneys on imaging, and what we call a bland urine sediment, meaning there's really no blood or protein. A really unique clue can be a history of gout that shows up way earlier than you'd expect for their stage of kidney disease. That's a great pearl to remember.
Now, what if the main feature you're seeing is hematuria, blood in the urine? Well, then you have to start thinking about defects in type 4 collagen, which is a super important protein in the kidney's filter. This table breaks down the two main players. On one side, you've got hereditary nephritis, which you probably know as Alport syndrome. It's progressive, and it's classically linked with hearing loss and eye problems. On the other side, you have thin glomerular basement membrane disease. This one is almost always benign. It just causes some blood in the urine and has a great prognosis. Telling these two apart is absolutely critical for counseling your patients about what to expect.
So, we've walked through this whole diagnostic framework. But once you've actually got a diagnosis, what do you do next? What do you actually do for the patient? Let's shift gears and talk about management. For ADPKD, our most common genetic kidney disease, the approach is pretty systematic. Step 1, and this is the most important, is aggressive blood pressure control. RAS blockade with an ACE inhibitor or an ARB is key. Step 2, you manage the complications as they come up, the pain, the UTIs, the stones. Step 3, for patients who are at high risk of progressing quickly, there's a specific drug called tolvaptan that can help slow things down. And finally, Step 4, like we mentioned, you have to screen for those dangerous intracranial aneurysms.
Now, a really critical pearl about tolvaptan. This is not a benign medication. It works by blocking a hormone called vasopressin, but it comes with a significant risk of liver injury. This is such a big deal that there's an FDA-mandated safety warning. So, if you have a patient on this drug, you absolutely have to monitor their liver tests, and you have to do it frequently.
To wrap up, I want to touch on a really important topic where genetics, population health, and health disparities all intersect. And the story of the APOL1 gene is just a perfect and really powerful example of this. So there are certain risk variants in the APOL1 gene that are much more common in people of recent African ancestry. If you inherit two of these high-risk versions, what we call the high-risk genotype, it dramatically increases your risk for several types of kidney disease. And the numbers are staggering. We're talking about a 10 times increased risk for FSGS, a 7 times increased risk for kidney failure blamed on hypertension, and a whopping 29 times increased risk for kidney disease if you have HIV. It's one of the strongest genetic risk factors we know of in all of medicine.
So you have to ask the question, why would a gene variant that's so bad for the kidneys become so common in a population? Well, this quote gives us a fascinating potential answer from the world of evolutionary medicine. The leading theory is that the very same gene variants that damage the kidney also protect against African sleeping sickness. It's just a profound example of a genetic double-edged sword and a great reminder of just how complex and fascinating the story of genetics and disease really is.